On this Sunday morning, I have already two confessions to make. The first confession is that I have talked at pharma-organized meetings. And the second confession is that, unfortunately, Dr. Dick Quackerbaum was planned to give this presentation, but he had to undergo major surgery, and he's still recovering from it. So I'm giving this presentation on behalf of Dick Quackerbaum. And next to Dick Quackerbaum, you see the godfather of PRRT, Eric Krenning. So what I will do in the next 25 to 30 minutes, I will introduce the topic of somatostatin receptor imaging and peptide receptor therapy, starting with somatostatin receptors and somatostatin itself, and then show you some data from recent controlled trial and some future perspectives. So the field where what we are talking about is the field of neuroendocrine tumors. And I will mainly focus on neuroendocrine tumors of the GI tract. And there are several available options depending on the situation per patient. So most use nowadays first-line therapy with somatostatin analogs on the basis of two big international trials, PROMIT and Clarinet. Everolimus and sunitinib are registered for pancreatic neuroendocrine tumors, and everolimus recently became registered in the US for digestive tract and pulmonary neuroendocrine tumors. Some use temozolomide-based chemotherapy, other chemotherapies and liver-directed therapies, varying from debulking to RFA to embolization, whatever. But as told, I will focus on PRRT. So we all know that somatostatin has several actions. It's a neurotransmitter, it's an inhibitor of exocrine pancreatic function, it's an inhibitor of many hormonal secretions. And we know that cells that are controlled by somatostatin express high affinity somatostatin receptors on the surface. And here you see a broad field of cells expressing somatostatin receptors. And as told, I will mainly focus on GI and pancreatic neuroendocrine tumors, and especially the low-grade tumors, the grade 1, 2 tumors, and not the grade 3 neuroendocrine carcinomas. And of course, these neuroendocrine tumors also are very prevalent in bronchopulmonary in the bronchopulmonary tract. So, one of the most important somatostatin receptors for our topic today is the somatostatin receptor subtype 2. And this slide shows you an immunohistochemistry picture. In the upper right corner, you see the staining of the somatostatin receptor, and you can see membrane staining or cytoplasmic staining. And then in the lower left corner, you see displacement by cold peptide, showing that this is indeed specific staining. And neuroendocrine tumors express these somatostatin 2 receptors in high numbers. And that can be tested several ways, by RT-PCR, by immunohistochemistry, what I have shown previously, in situ hybridization, northern blotting. And we are quite lucky that these tumors express these somatostatin receptor subtypes 2 many times in high numbers. And the reason is that the currently available somatostatin analogs, the long-acting somatostatin analogs, have a very high affinity for the somatostatin receptor subtype 2A. So the lower these numbers, the higher the affinity, and you see a high affinity of these two pharmaceutical compounds for the subtype 2 receptor. So what happened in 1988 is that we performed the first scan with iodine radio-labeled octreotide in a female patient with MEN1 syndrome. And the female patient was known with a pituitary adenoma, prolactin secreting, and with a pancreatic endocrine tumor secreting gastrin. And What you see here is that, in fact, a supraclavicular lymph node was shown clearly to be positive on the scan, but also a lesion in the skull, which in fact was not the pituitary tumor itself. It was a large sphenoid meningioma, which also are known to express somatostatin receptors. Furthermore, the pancreatic endocrine tumor lymph node metastasis was shown. So in fact, this is the first somatostatin receptor scan that was performed. Later, indium-labeled pentritide was used, and this is commercially available up to date. And what this scan normally shows is uptake in the pituitary, in the thyroid gland, the liver, the spleen, and the kidneys. And as it's secreted via the bile, you can also see radioactivity in the bowel. And scans are usually made after 24 hours after injection and sometimes after 48 hours. And the pictures that you get are pictures like this. These are two examples of patients with high tumor load, neuroendocrine tumors with several metastases, like at the left side, a rectal neuroendocrine tumor where you see bone mets, lymph node mets all over, metastasis in the spine. And at the right side, you see a huge thymic neuroendocrine tumor with lymph node, bone mets, and mets in the skull. Nowadays, we tend to use more accessible PET images like gallium-labeled DOTA-TATE, DOTA-NOC, or DOTA-TOC. And the advantage is that these images are more superior than the octreoscan images. And of course, it's also more patient-friendly because you can do a PET-CT 1 hour after injection of the radio-labeled compound. And here you see an example of a patient with several liver mets, a big liver metastasis with a necrotic area. Here again, a liver metastasis with central necrosis. And this is another example of a patient with a supraclavicular lymph node metastasis and a central peritoneal lymph node metastasis. Of course, you see uptake in the kidneys, and with this technology also the adrenal medulla specifically is shown. So from targeted somatostatin receptor imaging, we've moved to targeted somatostatin analogs. And that there are two options here. We can use either radio-labeled beta or alpha-emitting compounds, or chemotherapy-labeled compounds like used by the former Nobel Prize winner Shelley in New Orleans. So the peptide is coupled to a radionuclide by a linker. The linker is DOTA or DTPA. And the peptide coupled with the radionuclide sticks to the receptor like a key on a lock. And the lock is the target. And here you see the example of lutetium-177 octreottate. In fact, there are many radio-labeled somatostatin receptor analogs that can be used for peptide receptor radiotherapy. You see here the old-fashioned indium-111 octreotide that we use for imaging, but this is a compound that also emits electrons, and by emitting electrons you can have some cell death. But we've moved to yttrium-90 labeled or lutetium-177 labeled compounds as shown in this slide. And also that the peptides differ. For instance, you can use octreotide, lanreotide, octreottate. And you have to realize that by changing the peptide or changing the radio-labeled compound, all the properties of the compound also change. I will come back to that. So this slide shows you that the tissue penetration varies between the different radio-labeled somatostatin analogs. The indium-111 octreotide only has a tissue penetration of 10 micrometers, whereas octreotide coupled to lutetium-177 has a tissue penetration of almost 20 cells. Octreotide was used because it has favorable in vitro binding characteristics. It was tested in animal studies and was also very favorable. And it has a higher tumor binding than indium-111 octreotide. And here you see the difference between octreotide and lutetium octreotide. Lutetium octreotide also emits gamma, so you can make post-treatment images, as is shown in this slide. And you see the superiority of the imaging using lutetium octreotide as compared to octreotide. And here's another example of a patient with a metastatic pancreatic carcinoma where you see a clear uptake on the planar imaging already in the tumor and the tumor metastasis, whereas the indium octreotide doesn't show that great imaging unless you start using SPECT imaging. So the way this works is as follows. As you can try to imagine that the cells with the colored rims are the receptor-positive cells. There can also be, like in prostate cancer or other cancers, receptor-negative cells. And if you use a compound like indium-111, which has only a penetration of one cell, it will enter the cell, it will be internalized, and it will give radiotherapy to the cells, and the cells in the end hopefully will die. But if you use the other compounds that have a very long range, or a relatively long range, you get what you call crossfire radiotherapy, and these radiation also kills the surrounding receptor-negative cells, so in the end, the tumor effects are much better. So there are groups that decide on the basis of the tumor size which radio label they will use. The first patient was treated with the imaging compound, indium-111 pentriotide. So this is an electron emitting compound which has only a tissue penetration of one cell. And this was a patient with a glucocarcinoma, and you see at the right panel, you see all the images over the time, and here at the green bars, PRRT with indium-11 pentriotide was given, and here you see the response, and you see a biochemical response here with regard to glucagon levels, and you see a tumor response here. But that was the first tryout, and we rapidly moved to better tracers, in our opinion, like lutetium-177. So when we start treating a patient, this patient should have, of course, a pathology-proven inoperable tumor with uptake on the octreoscan. Well, our inclusion criteria up to date are no prior therapy with other radio-labeled compounds, performance score, blood counts, kidney function, very important, and of course science-informed consent. And if you want to read more about it, there's a beautiful website with a very beautiful video also how it works. So the maximum administered dose, like in therapy for thyroid cancer, is determined on the basis of bone marrow dose and kidneys. So the first therapies were given with a maximum of 800 millicuries, and that was divided over 4 cycles of 200 millicuries with 6 to 9 weeks intervals. So the full patient dose is 800 millicuries, or 4 times 7 gigabecquerel, so close to 30 gigabecquerels. Here you see how it works. A very happy patient and a very happy nurses. They administer you with amino acids. That's to increase the clearance of the radio-labeled compound from the kidneys, so the kidney damage will not be as high. Antiemetic, and then the lutetium octreotide is infused in 30 minutes, and patients, according to Dutch law, have to be in the hospital for 1 night because they excrete radioactivity. And Dick Quickerbaum, who unfortunately cannot give this presentation, in 2008 reported on the results in a big cohort of patients. And you see that there's, he looked at patients with stable disease, minor response, partial response, and complete response. And you see minor response in about 17% of the patients, partial response 28%, stable disease 1/3 of the patients, and still 20% of the patients did not respond to this therapy and progressed. Initially, patients that were stable at baseline and progressive at baseline were included. Later it was said you should only treat patients that are progressive because these tumors can be stable over a long period of time, so you don't know what you're doing. But in this slide you see in the green line the patients that were not progressive at baseline, and the blue line those who were progressive at baseline. And in fact, the time to progression didn't differ in this series of patients. And the time to progression was 40.2 months. Remember, this is an important figure. And also realize that, for instance, everolimus and sunitinib in pancreatic neuroendocrine tumors show a time to progression median time of 11 months. According to the uptake on the somatostatin receptor scan, the tumor response can be predicted. The higher the uptake on a somatostatin receptor scan, the better the tumor response is. And this is according to a scale nowadays called Krenning scale. So the Krenning scale 2-3, that means uptake equal or slightly higher than liver. Higher than liver is Krenning scale 3, and extremely high uptake is Krenning scale 4. And you see the higher the uptake, the higher the tumor response. And I will show you a few examples. This is a patient with a large, inoperable tumor of the pancreatic tail that has significantly reduced in size after 4 cycles of PRRT. And the patient also gained weight, and you see the sub-Q fat mass increase in time. And this therapy has also been used as neoadjuvant therapy or as debulking therapy before surgery, because you can imagine if the tumor shrinks a lot, maybe the patient becomes operable. Another example of a patient with a huge liver metastasis with central necrosis, and you see a very impressive reduction in tumor size after 4 cycles of PRRT. Also, the patient's quality of life, independent of tumor response, improved. And this was done according to the ERC C30 questionnaire. And you see all kinds of parameters improved in red after therapy, so fatigue, insomnia, and pain, for instance, as shown in this slide. What about toxicity? As a matter of fact, acute toxicity is rather limited. Patients can present with nausea, but I've shown you they get antiemetics. Some patients experience pain because of effects on the tumor, for instance, pain in the liver. WHO grade 1 hair loss occurs in 62% of patients, and WH grade 1 2 nausea or vomiting with a duration of less than 24 hours occurs in a limited number of patients. Hematological toxicity is frequently observed, like leukopenias or drop in leukocyte counts, drop in hemoglobin, and drop in platelets. But you see that the grade 3-4 toxicities are rather limited, only 3.6%, or patient-based 9.6%. Serious side effects, however, do occur. Renal insufficiencies in 2 out of 504 patients in this series, liver toxicity, and regretfully also myelodysplastic syndrome. And there was recently a publication from Paris showing that myelodysplastic syndrome and leukemia occur in patients that were pre-treated with alkylating chemotherapy. So there's a warning here. that you should be very careful with regard to the use of alkylating chemotherapy followed by PRRT. So overall, the serious side effects are only in 2% of the patients, which in oncology is not much. So this was all non-randomized, uncontrolled studies, and of course oncologists were always discussing that this was not the way how we do clinical research in oncology. We need controlled trials. So in the end, there was this controlled trial called NETTER-1, and everybody asked me about his abbreviation, but as far as I understand, it's NET from neuroendocrine tumors therapy, as written in Italian, so without an H. That's the abbreviation. The NETTER-1 trial was an international trial performed in Europe and the US. It enrolled almost 230 patients, and the patients were randomized to undergo PRRT according to the Rotterdam schedule, or since they were all progressive on 30 milligrams of octreotide, the somatostatin receptor analog, they had to increase the dose to 60 milligrams in the control group. There are no data, well, there were no data up to then whether increasing octreotide would be very beneficial, but this is how it was settled with the FDA and the EMA. The follow-up was 5 years. And this trial was recently reported at several international meetings. And here you see the result with regard to progression-free survival. There are hardly any data still about overall survival, but the impression is that with an increase of progression-free survival of 40 months, of course, this will influence the overall survival as well. And what you also see is that apparently there is an effect of increasing the octreotide dose, and this is studied now in different trials, for instance, a trial using high-dose lanreotide. Interestingly, this 40-month PFS, I already showed you before in the trial or in the report by Dick Quickerbaum many years ago. So it's the same. Here you see the response rates, so objective response rates in the octreotide in the PRRT group, about 19%. 5% of patients were still progressive, and stable disease was achieved in 2/3 of patients. So what have we learned from therapy with lutetium octreotide? We see high tumor response rates with limited side effects. There are some factors predicting success, like I've shown you, the high tumor uptake, and we have also learned that patients with limited liver involvement do better. Factors predicting survival are performance score, limited tumor mass, absence of bone metastasis, and absence of weight loss. And in the future, we can think of all kinds of new approaches. Chemosensitization, like is done with 5-FU, combination of radionuclides, those with a long range emitting compounds, and those compounds that have a short range. Adjuvant therapy, so patients that are cured according to surgery, maybe give them 2 cycles in an adjuvant session. We have some unsolved issues, like is there a role in stable disease, and what's the optimal dose, and what's the optimal dosing interval. What we also will see in the near future, is receptor antagonists. So in the left panel you see the receptor antagonist, in the right panel you see the agonist. So I've been talking about receptor agonists, so they only show binding to activated receptors. But the antagonists bind to activated and non-active receptors. And several compounds were studied, as shown in this slide. So here you see the antagonist with affinity to somatostatin receptor subtype 2 or subtype 3. And these receptor antagonists remain on the surface of the cell. They are not internalized like the agonist. So the agonist is taken up by the cell, gets close to the nucleus and starts emitting its radiotherapy. The antagonists, they remain on the surface of cells. But there have been some publications in this field on two compounds, a compound used for PET imaging and a compound used for PRRT. This is mainly work from Switzerland. And here you see an example of a PET scan using a receptor antagonist as compared to DOTA-TOC, a receptor agonist, and you see the PET image on the right using the antagonist is even more superior than the PET image obtained with the agonist. And of course, somatostatin receptor scintigraphy, like used with indium-111 pentriotide, is less superior. So, I think with regard to the therapy of low-grade and intermediate-grade neuroendocrine tumor, we have an expanding spectrum of available therapies. There is still no idea about the order on which subsequent therapy schedule should be followed, but I hope I've shown you that PRRT is a very favorable compound, especially because of its long PFS. And yes, I try to show you today some insights going from somatostatin to somatostatin receptor antagonist. And I think we will hear a lot more about this in the future. Well, this project is carried out by a lot of people in our center. Of course, there's the involvement of the Department of Nuclear Medicine, especially Professor Dick Quickenbaum, Eric Krenning, and their colleagues, but also the colleagues from endocrinology, internal medicine, oncology, and surgery. And this is a typical example of multidisciplinary approach in patients with complex diseases. I thank you for your attention.